Morning, May. Great. So for everyone on the line who can hear me, the way we'll try to manage this process with a lot of folks on the line is to use the chat box to collect questions. So please feel free to open that up and jot down any questions you have along the way. Jaime, do you want to just quickly welcome everybody and then we can get started with George?
Thank you, Colin. Thank you, everyone. Good morning. This is our first town hall with a faculty-affiliated group. I want to thank Mike Lipnick, Colin, Kim Batzel, and many others who have proposed that we have a series of town halls to stay in touch with our community and learn from you about your concerns and your conditions overall. So I'm aware that there is a lot of information coming your way from very many sources. I believe UCSF has done a very good job in terms of reaching out and giving precise guidelines. So I'm quite impressed with the leadership of Chancellor Sam Howard. But the idea is that we all in the cabinet cascade reaching out our own communities to have a more personal interaction and to learn from you any ideas or concerns that we might want to bring to the overall UCSF policy. So I will stay for the first half of this town hall, and then I will have to run and join another webinar. But I will let Mike Lipnick to lead this and Colin helping moderate as well, because this is a faculty-affiliated group, and Mike is the chair of the executive committee. We want to make this a regular town hall meeting, so please do not hesitate to bring whatever ideas, concerns you might have. Mike?
Sounds good. Thanks, Jaime. Just building off of what Jaime said, goes without saying this is an unprecedented time and we wanted to provide some forum here. We know there's a lot of email and information overload and perhaps even some town hall overload. So we want to keep this specific to information relevant to our global health community. The primary goal really is just to provide a venue where we can all share information that might not be coming through some of the other channels, but also facilitate some discussion moving forward relevant to some of the important global health equity topics that may also just be absent from the conversation in other spaces, whether that's how the pandemic's affecting vulnerable populations with our groups in Navajo Nation or the streets of San Francisco or sub-Saharan Africa or wherever. I think there's some relevant pieces of the discussion that we can facilitate group moving forward. So without further ado, we'll jump in. I appreciate everybody's time, especially to the panelists who agreed to share some information with us. So first up is George Rutherford, part of the IGHS leadership. I think everybody knows him, but professor of epidemiology and biostats, director of the Prevention and Public Health Group, somebody who we turn to for information on COVID for weeks, if not months. And thank you very much, George, for taking the time to share with us some of your insights.
Sure, thanks, Mike. Everybody hear me okay? Yep, John. So I'm gonna jet through these just so people are brought up to date. This is numbers as current as of yesterday. There are more than 220,000 cases that have been reported from 159 countries and territories. If you look overall, there are 9,000 deaths. When I first put this slide set together, 97% of the cases were from mainland China, and that's plummeted as the epidemic, as the focus of the epidemic has moved to Europe and to a lesser extent the Middle East. The other countries that are affected are Italy, Iran, Spain, Germany, the US, France, and South Korea, which is kind of an interesting object lesson because it's kind of come and gone. This shows you, there are a couple of good news things. This shows you the cases by date of onset and date of diagnosis in China. I don't know why I said 2018 to 2019. I'm sorry. I'm getting punch drunk. These are, you can see these going away. There have been no new cases, no new domestic cases in China for the last 2 days. All the cases have been imported. So I think we can say if there's no rebound, which is something we're looking very closely at, this has been successful. Similarly, this just shows that long tail. If we look worldwide, you can see this big outbreak in Europe. There's also another big outbreak here in Iran and the Persian Gulf. It's led to the Korean outbreak has kind of come and gone. Cruise ships, skip cruise ships. There's all sorts of messes with cruise ships. This shows you, kind of gives you an idea of what's gone on. This big peak in China here in the Western Pacific region, that was from a change in case definition where they added 19,000 cases in one day. And the change in case definition was they allowed chest CT scans consistent with COVID-19 to be reportable. But you can see here how Europe has really started to dominate the picture here. So these are the stories about Italy and South Korea. South Korea, the cases have come and they're down. They're under 100 cases a day from highs of just above 800. So I think that's a success. If you look at what they've done differently than us, when we had done 829 cases, they'd done 829 tests. They'd done 170,000. They've now done more than 270,000 tests. They're very aggressive at finding people and putting them in isolation with not a lot of other things. This is in Italy. I don't know how good your Italian is, but you can see that there's this concentration up here in the northern part of Italy in the Lombardy region. This is actually by province, and the provinces are smaller than regions. The cases are continuing to go up. Italy has surpassed China in terms of total number of deaths as of this morning. That's deceduti, or dead. And then the other thing to note up here is that there are almost 3,000 healthcare workers that have been infected. Again, there's this sort of male predominance here in the blue, and most of the serious cases, these deceduti again, are deaths. And are deaths, and letalità is the case fatality rate. So you can see how it's much higher in the older groups. There are not a lot of cases that have been recognized down in here. Pediatric cases are an interesting problem because there are there have been some new reports from China, and also the first US statistics have come out, and it's clear they're hospitalized pediatric cases. So it's not like you get a total pass if you're under 40. Europe has done a lot of things that the EU has, the European Commission has banned all non-essential travel into the EU for 30 days, much like the US is doing. And there are a whole bunch of new border controls have put into place. All the large outbreaks in Germany, Spain, and France have all moved to shelter in place, like in Italy. One public health note was when we go through all these lists of exemptions and who's exempt. So, in California, it's hardware stores and home improvement stores. In France, it's tobacconists, the tobacco stores. I think that's because it's where they buy the lotto tickets, and that's a big source of funding for the government. Iran has had a big mess. There is some back and forth. Iran tries to maintain good relations with China, and so it kept the borders open for a long, long time when everybody else was shutting them out. And there are Muslims in the west of China, and they go back and forth with to this sort of the Vatican of Shia, which is a city called Qom. The U.S. So this was as of yesterday, 9,500 cases and 150 deaths. This has gone up substantially in the last 24 hours, mostly in New York City, because they made testing widely available, and all of a sudden they started to diagnose cases. So as of yesterday, there were 3,000 cases and 3,000 cases in New York City. In New Rochelle, there was this kind of exclusion zone created, which was one of the first places it hit. And we think we're going to see the first critical care crunch in New York City. The mayor has asked the president to send one of the hospital ships. There's one on the East Coast, one on the West Coast, one of the Navy hospital ships to to New York Harbor to help take care of the influx of patients. These are the first set of U.S. data that have come out. And you can see that there are a lot of hospitalizations down here in the 20 to 44-year-old category. 0 to 19, there are not that many. But you can see there are also ICU admissions in here and deaths down here in these younger age groups. Now, of course, it goes up with age, but it's not 0 in the younger age groups. So California, the governor yesterday issued a shelter-in-place order for the whole state, and didn't order. He asked businesses to close. He's also requested the president send the other hospital ship from San Diego to Los Angeles to help with overflow. As you all know, let me come back to that. As you all know, we've had a shelter-in-place order from the county health officers there are now 9 Bay Area counties that appears to be holding. I go out every morning, and I didn't see very many people out and about today. So you guys are all living the consequences of this as we speak. The interesting thing about California, these are data from Charles Chu, is that there are different clusters. There appear to be different introductions into California in these 3 different clusters. This is the Washington State cluster up here in pink. There's a Solano County cluster here in kind of toothpaste green. And then down here in whatever this color is, mauve, there's a San Benito cluster that focuses around a returning traveler. We think there's been a single introduction in San Francisco, probably in late February, and we're basing the models off of that introduction. But there are these different clades in the state, whereas in Washington, it seems like it really was a single introduction. Okay, now we can skip all this stuff unless people want to know. And come back up to, so the strategic goals of public health are to decrease the effective reproductive number, R sub E, and then flatten and prolong the outbreak. And the reason we want to do that is because otherwise the healthcare resources will be taxed, as I'm sure you're all feeling, and also to buy time for antivirals and eventually vaccine. This is an interesting slide. It shows you kind of within the effective reproductive number where the various points are that public health can influence. And this is kind of what we think is this makes sense from a public health standpoint. It's also fairly doable. I've been modeling this with Paul Wesson for San Francisco, and we get a curve that looks very much like this with a R sub 0 of 0.64, which is twice what it was in Wuhan after the lockdown went on, figuring it's not quite as effective as it is in China. But you do get very similar projections looking like this. Wash your hands, where you should on an airplane. We've gone all through this stuff. This is interesting. So this Wang and colleagues reported the epidemiology of 26,000 lab confirmed cases in Wuhan through the 18th of February. They looked at before January 11th to 22nd, January 23rd to February 1st, which is the first week after the first 11 days after the shelter-in-place order went out, and then the following. So you can see up here in the upper right how the R sub E fell from around 3.8 per 3.8 cases, secondary cases per every primary case, to 1.26 here immediately following the lockdown, and then once it became effective to 0.32. So we're using these numbers in our models. The other thing to notice, and this is really important, is that they estimated at the worst case that 59% of cases were unreported. So all these numbers you see, about 20% of people going to the needing to be hospitalized, and 5% need to be on ICUs, and 4% need to be on blowers. That's based on the number of reported cases, not on the total number of cases. So you have to multiply whatever the projected number of cases is by 0.41 to come up with the denominator that underlies all the Chinese data and the Italian data. Okay, so this just gives you an idea. If you do it, say that we have an attack rate in a population of 1 million, these different attack rates, right? This is when you multiply it by 0.41. This is how many need hospital care, and this is how many would need ICU care, right? So this gives you an idea of what this would look like based on various attack rates. We think that the attack rate is going to be sort of up here at the 5%, 5 to 10% range. And we're doing all the math this morning in real time to project ICU bed needs going forward after we've agreed on. There are a couple of different groups here that are working on curves. Paul Wesson is one. Maya Peterson at Berkeley is another, working with Diane Havler's group. And we're going to come up with a consensus set of estimates for high, medium, and low. Okay. There's been a lot of press for this Imperial College model that said, you know, here everybody's going to die in the upper panel. This gives you down here in the lower panel. It gives you the effect of these various intervention strategies. The blue line down here is basically not as much as we've done. It's what the governor announced about 2 weeks ago. We're going to actually have an even flatter curve because we've done real shelter-in-place stuff. The red line down at the bottom is the British capacity for beds. So, you know, whatever. It's gonna still take some extra beds over time. All right, we can skip all this stuff. So this is another important point about what are the lessons from the 1918-1919 influenza pandemic. The first is that you need to begin social distancing early, as happened in St. Louis. This is all mortality here on the y-axis. Other cities, Philadelphia most notably, was having parades, was screwing around while Rome burned, and didn't do anything until quite late in the epidemic, somewhere around here where the second derivative is. The other thing, unfortunately, is that St. Louis, after a month or 2 months of having the city pretty much locked down, let their foot up off the brakes and had a rebound in December, which they then had to reinstitute things, but it went away in a month. So, you know, for us, the lessons from the 2009 influenza was that we did a bunch of stuff. We closed the schools in late May, mid to late May. We got into the summertime. When schools came back in the fall, there were new spikes in infection, but luckily the vaccine came online in the fall, for those of you who remember that. And so that was able to blunt the effects in the fall. All right. This is a federal package. I can talk to you about that. So this is the order from the health officer. This is great. Can you imagine a title this long? Think that somebody would have told you to shorten it. Right. But see, it's also may need to provide or receive essential services or engage in certain essential activities and work for essential businesses and government services, exempting individuals experiencing homelessness from shelter-in-place order, but urging them to find shelter, directing all businesses and governmental agents to cease non-essential operations at physical locations in the county, right? So this is pretty much lockdown. Okay. Now, this is the most important slide here. There are two adjacent counties in Italy. One is called Lodi, not Lodi, although I keep saying that. And the other is Bergamo, and they're both in the Lombardy region. Lodi started its lockdown after this, right before this first wave. whereas Bergamo didn't start for 2 weeks later. And now we are out here in real time. You can see how flat the Lodi curve is, but in Bergamo there's this big influx, so it's about 5 times higher. So that's, I think, an incredible experiment of nature that we can observe to say what's the effect of these big lockdown shelter-in-place interventions. So yeah, you pronounce how you say lockdown in Italian, lockdown. Il contagio, the contagion. Yeah. So what are we seeing in California in the Bay Area? These are not updated. There's one more day here. Look at how it's flat here, right? Are we really starting to see some flattening here? Kind of cool. Okay, and then that's it. This is at my movie theater on Lakeshore and 580 in Oakland. So on that note, I'll end and happy to answer questions or move on to the next.
Thanks, George. Thanks very much. Anybody who has questions, please put them into the chat box. We're going to continue moving through the speakers, and then we'll take questions at the end. Just as a few folks have asked for slides, and we'll get back to you on that. But remember, next week, Grand Rounds, George is going to be presenting what will be a much more comprehensive talk. So everybody, please keep that on their calendars. It's in the IGHS calendar at calendar.ucsf.edu. It'll be Thursday at noon next week. Thank you again, George. So next up is Sri Shamasundar from the HEAL Initiative. Sri is Associate Professor of Medicine at UCSF and co-founded the Health Equity Action and Leadership Fellowship Program. He's going to tell you a little bit about the fellowship program, but Sri's experience has ranged and includes a variety of settings, both here in the US as well as South Asia. Sri's going to talk a little bit about the importance of solidarity with our partners in global health, especially during times of crisis. So Sri, thanks for taking the time. Appreciate it.
Thank you. And this is such a great forum. I think just George kind of laid out so many things that I think global health folks understand deeply. And I think that going forward, I'm interested in seeing how global health sciences and UCSF can respond as some of our partner sites in, more of the global South and some of the health systems that we know are weak if they start seeing the level of outbreaks in sub-Saharan Africa and South America and other parts of the world. How are we going to respond? Are these slides coming up?
Yeah, do you want to share, Sri, or I can share? If you're online and you want to control it, go for it. I can do it for you if it's easier.
Yeah, I can share as well.
Oh, then I'll stop. Okay, sorry.
Sorry about that. Can you guys see it?
Yep. Yes.
All right, so for those of you that don't know much about HEAL, it's the largest global health fellowship program in the country, as well as the largest fellowship program on the order of, I think, the size of the residency at UCSF in medicine. And so it's a 2-year global health fellowship based in really immersion of health professionals trying to understand what it means to take care of underserved populations. And then half of the fellows are either US doctors and nurses. A quarter of them are Native Americans, so from Navajo Nation in doctors, nurses, other allied health professionals, and then another quarter are from low and middle income countries, and about 9 countries around the world. And so we've now had 5 years of HEALs at UCSF, and so it's from 2015 to 2020. It's going to be our 6th class this year, and so I think HEAL has this incredible vantage point of an incredible diverse frontline health worker community across the world. And so we have 3 sites in sub-Saharan Africa. We have a site in Mexico, Haiti, and several sites in Navajo Nation. And so really a vantage point of what frontline health workers are are doing in those capacities. And as we know, a lot of these communities they're starting to have small amounts of cases, but really nothing like we've seen in China and Italy yet. And so I think one of the things that I wanted to talk about is, some of the decision making. We were around during Ebola in 2014, and we actually had a hospital medicine. We hadn't yet started HEAL, but we had 2 fellows that were scheduled to work in Liberia for their job. Like, part of their fellowship was to spend half their time at UCSF and then half of their time in Liberia. And at that time, it was very much it was a conversation that was ongoing that I think we learned a lot from, about whether our trainees, whether our fellows, how should UCSF show up in some of these contexts. And so I would say in this conversation starting in February and March, and we had 7 US fellows that are employed by UCSF as part of their fellowship, and they were in different parts of the world. And essentially there was this question with the GME office as well as with the chancellor, as the State Department ramped up the desire of folks to come home, what should be the role of our trainees. And I think that there was this question that I think will recur at UCSF of liability versus solidarity, and what should the risk that we put some of our trainees in, especially when there's unequal risk as HEAL, because we have fellows that are both from the global south but are actually employed by UCSF, and then we have US trainees. We had a lot of different conversations about some of the guilt that as you decide to leave in order to, especially in this case, I think some of the isolation with the travel bans and people anticipating that they'll be in place in country for a long period of time, and knowing that a lot of their colleagues that are also HEAL fellows, often are nationals from those places, but are not having choices about leaving, and especially in the context where a lot of these health systems are understaffed. As we know, the health workforce is stretched continuously. And so right now, we actually had 4 of our US citizen fellows that are either returned or en route. And then there's still 3 that have chosen to stay. And that's has been approved by the GME office and the chancellor, which I think is a conversation that I think global health sciences and can lead, of this question of what does it look like to be in solidarity. And I think this played out during Ebola, where Fook and I, who Fook is the other co-founder of HEAL, wrote a quick Huffington Post article where at the time our fellow was not allowed to work in Liberia, even though as her fellowship, she was a fully trained medicine and pediatrics doctor and could have been an attending anywhere. And she joined this fellowship. And as Ebola started to rage in West Africa, the conversation was really trying to pull her back. And so I think that we had this analogy of, as a building is burning and you're a firefighter, what would a serious undertaking of solidarity look like? And so we wrote this piece in the Huffington Post that got picked up in a bunch of places and actually led to a New England Journal piece of U.S. trainees in the Ebola epidemic. And I think this is where IGHS could really lead the conversation as coronavirus, all of the conversations that all the partnerships that we have across the world, and all the different vantage points that we're going to see from our partners, whether it's in Sub-Saharan Africa or South America, what are they seeing and what are they really going to need from UCSF, and what does it look like to be in solidarity? Because, as we know, if Italy and China are completely overwhelmed, if if this level of outbreak starts to occur in a lot of our partner regions, what does the conversation look like that really broadens it outside of the walls of UCSF? And I think this is just a last slide. Some of you guys may have seen this of Malcolm Gladwell has this conversation of soccer versus basketball, and he talks about how the 11th player in soccer, it's much more important to have a strong 11th player in soccer, and it enhances the whole team. If you have one superstar in soccer, you're going to actually not be an amazing team, as opposed to basketball, where if you have one superstar like Kobe or LeBron, oftentimes the teams can really take off. And in terms of health systems, I think what we're seeing, obviously everything that global health folks already know is we're just as strong as our weakest health system. And so, leading these conversations about equity, about vulnerable populations, about things that, our partners know really well about, contact tracing, about using community health workers. How do we tap in those knowledge and bring them into the conversation? And I think that at this moment, there's really a chance for IGHS to lead, to have these conversations with our partners and bring them into articles that we're writing. Where we actually just published a BMJ blog today and 3 of the authors are nurses from Haiti and 2 from Liberia that are talking about some of the stigma, some of the stretch that they faced being in ETUs during Ebola. And so really these vantage points that I don't think are highlighted that much in this outbreak, but maybe something that we're going to need more and more. I think that this is my last slide. Really, there's been a lot of conversations. I think the global health conversation around equity and inclusion, reciprocity, bringing a low and middle income country voices to the table, and really modeling equity. What does it look like? And I think HEAL's focus is really how do we walk the walk of equity in real time. And there's been a lot of critique of global health in terms of especially global north universities that, whether it's research papers or otherwise, don't necessarily hit that bar of equity. And I think that there's a progression that we're trying to live into. And I think this Dr. Pai was ground round speaker here in early February, talking about where does global health need to go in terms of more than a makeover and leading with equity. And I think this COVID-19 moment, actually, this is a quote from Naomi Klein, who talks about that I think is quoting economist who says, only a crisis, actual or perceived, produces real change. And then when that crisis occurs, the actions that are taken depend on the ideas that are lying around. And so a lot of the ideas and the reimagining of how we work in global health with real solidarity, I think will be tested over the next several months. And what does it look like to do that beyond the walls of UCSF and really bring a lot of our partners into the conversation, because I think that's where IGHS can really lead. I'll stop there.
Sri, thank you so much. Colin, I turn it over to you for some questions.
Yeah, so thank you for those who've been dropping questions into the chat box. A couple of announcements of things that are coming up. First, I think it was noted by Michael that George's presentation on the COVID-19 situation will be the feature of our IGHS Grand Rounds next week. The IGHS website will have a link to upcoming events related to the COVID-19 crisis. If you are ever wanting to know when various presentations, panels, and the like are happening, we will have that on our website, so you can go there for ones that'll be a little bit more directly steered towards the global health topics, but also we'll also link to campus events if the campus is putting on broader topics like that. In addition, thank you from David, who noted for those who are caregivers at this time, the American College of Occupational and Environmental Medicine is doing a webinar today at 9 a.m. on COVID-19, protecting healthcare workers, lessons from Taiwan and Italy. So if you're a frontline worker, please be aware of that. And so that's something that may be a resource for you. George, if you're still on and we have you for a little bit longer, there were a couple of questions on the chat box around testing and kind of clinical treatment. And I'm wondering if you could say a few words about sort of the state of testing, kind of where we are, what we've learned, and give maybe a brief overview of that, if that's possible.
Sure. So as of yesterday, there are two types of testing. There's polymerase chain reaction testing of the nasopharynx and oropharynx that looks for a viral RNA and amplifies it, which is what you hear about all the swabs and the tests and how we haven't done enough tests. That's that test. As of yesterday, in labs here at UCSF, we've developed an antibody test. So we can look, now we have the chance to look for old infection as well as current infection. The PCR tests are, they're state of the art. They're great. You turn PCR positive a day to two before symptom onset. And there are also, you can be a transmitter and be asymptomatic. It's also clear that there are people who have prolonged periods of shedding, just the regular clinical course of shedding, but who have minimal symptoms and really aren't recognized at all. And that's what leads to this underreporting. It's really underdiagnosis, underascertainment, whatever you want to call it. And that's probably much more common in younger people than older people, and was one of the reasons that schools got closed to keep that transmission down to a minimum. So that's PCR testing. Now the problem with PCR testing is, as you know, is that if you have any tiny little piece of RNA laying around, it'll get amplified. So, and the test can't differentiate between viable virus and fragments of viruses that are after they don't die per se, but after they've been broken up neutralized by the immune system. So if you actually look at cultures as opposed to PCR, you can also do cultures, but that's really a research tool. If you do cultures instead of PCR, you get there's a period of about 8 days after onset of symptoms until you become culture negative. PCR can persist, especially in things like rectal swabs, for several weeks afterwards. But I think that's all under the land of curiosity. There's been no transmission reported because of fecal oral contamination. There was some fecal transmission of SARS in Hong Kong. That was a pretty remarkable set of plumbing screw-ups that led to that. And that wasn't fecal oral, it was more like fecal droplet spread, if you can imagine. So that's that test. That's capacity is ramping up. You'll see pop-up tents in hospital parking lots. There's one at Parnassus. That's basically so you can isolate the people off who are getting tested, and you use the same, you use cohort the healthcare workers who are testing them together. So you're not exposing all the healthcare workers to the disease. We are the Chan Zuckerberg Biohub is being repurposed. Their PCR capacity is being repurposed to be predominantly a clinical laboratory, and will be able to handle 1,000 specimens a day when it comes up. We think that in the city we could probably get up to about 1,500, 2,000 specimens a day with that. We think that demand will be there, and it'll be spread out over a month or two. The other test is antibody testing, and right now this is just IgG testing, so it doesn't differentiate early from late, but it can be done on saliva or serum. And so the fact that it can be done on saliva opens up the possibility of a mail-out serosurvey while everybody's still at home, which is kind of an interesting idea if we get the swabs. Hopefully we'll be able to move to having an IgM test so you can use it as a way to diagnose acute infection as well. So that's where we are with testing.
And then there are a few questions. Let me that just popped up about, and Winona, actually, you jumped in with an answer to one of the questions. I know you're speaking in a few minutes, but can you say a word or two on UCSF policy with regard to testing of employees?
That's Winona.
Yeah, I mean, I can't, that's not my area, but it is my link there that I sent.
Okay.
Because I had some questions from my staff, so I did develop some information. We did our due diligence and looking on the internet to see what's available at UCSF. And the guidance that we found was that you're to refer to the occupational health and safety resources. There is a hotline, which I've given in the chat. You call them and they will triage you accordingly. If you've been exposed or if you think you've been exposed, they're recommending that you call that hotline and they'll triage and advise if testing is indicated and give you instructions from there. That's my understanding.
And they've been saying that there's they're inundated with phone calls and so there's a 30-minute wait time. And so most of their folks are hanging up after 15 minutes, but to just kind of stick on that line if you can.
Okay. Yeah. So I think hopefully the testing will scale up, but I'm sure there are lots of concerns about that.
It's better than it was last week. Yeah.
Yeah. George, there was another question about clinical presentation and treatment. So just any comments on that? Treatment option?
Yeah, maybe I can share a slide here. Well, I haven't asked. Never mind. So clinical presentation, the classic symptoms are fever, cough, dry cough, and shortness of breath. In some of the big U.S. series that are coming out now, that triad was only displayed by 15% of patients. So it's not totally foolproof. Fever is the most common symptom, about 85% if I recall correctly. And so what I've been telling people to do is buy thermometers and don't say stuff like, oh, I got this, I got that, I feel febrile. There's a fascinating company, and I can't remember the name of it, like Kinsa or something, that's putting out smart thermometers that will allow temperatures to be reported into the city health department. So they get sort of kind of surveillance of febrile illness. Sort of interesting idea. So that's one thing. There are a whole bunch of other symptoms that have been reported. Diarrhea is not that common, maybe 10%. Rhinorrhea in 15% or so. But the classic is fever, dry cough, and shortness of breath. The clinical treatment is if you have mild symptoms and you're not in a risk group, you don't get anything, right? You get sent home, you self-isolate. There are, I just got permission 1 second ago, so let me share my slides. Just came in, so sorry, let me just share this here. Oh, yeah, where are we? One thing I've gotten better at is Zoom, but it's still hardly foolproof.
We're all learning, George. We're all learning. There you go.
Okay. So this gives you an idea of the presentations of 21. These are ICU patients who came in. These are the underlying diseases, just to anticipate a question over here on the left. These are the admission symptoms: cough, shortness of breath, and fever. This is 11 out of 21, so it's 52%, right? And you're not getting this sort of big febrile reaction. What I wanted to show you was this. This is from Annie Lukemeyer at UCS at the General. So start down at the bottom: mild disease, no hypoxia, and no risk factor like age or underlying disease for progression. No treatment. Mild disease, no hypoxia, and risk factors for progression to severe disease. So this would be like me. Consider hydroxychloroquine. This kind of interesting drug that's it's really chloroquine, that's been studied, but hydroxychloroquine is what's available in the U.S. And they're kind of on case reports. I think they've been giving it out. And then the hospitalized non-ICU level care, moderate and severe disease, put them in a trial of remdesivir, which is an broad spectrum antiviral that's being tested, or hydroxychloroquine if remdesivir is not feasible for whatever reason. And then if they're intubated in the ICU, if they're in the ICU with or without intubation, appropriate management of ARDS, acute respiratory distress syndrome, ARDS targeted therapies, which are largely focused on blunting the immune response. These are like agonists to IL-6 and all the immune cytokines. And then either putting them in the remdesivir trial or getting it through compassionate access. So that's how they're treating inpatients at the general. So down here, you can see at the bottom of this, for people with mild disease, with no hypoxia and no risk factors, they'll most likely get sent home and asked to self-isolate for 14 days. So that's what we're doing right now. There's an interesting thing I heard about in Seattle, which is when they send them home with an FiO2 thing for your finger, an oxygen sensor. And so if they start to dip on room air, say below 94, they'll get the lab test transmitted in real time, and they would go get that person and put them into the hospital, thinking they're sort of at the verge of decompensating. I thought that was really an interesting use of telemedicine.
Thanks, George. Just building off of what you said, I think that how we are taking care of these patients at the general and at other sites is evolving, and a lot of these, especially the trials that are ongoing, they are trials. So we're trying to, at the end of the day, we're focusing on what evidence we do have for taking care of critically ill patients with hypoxemic respiratory failure or multi-organ failure, and maintaining a healthy dose of skepticism and with these trials that are ongoing. But it'll be interesting to see how things unfold. Just in the interest of time, I think we'll move on. Joe Novotny and Winona Ward have joined us, and we want to make sure that we give them some time to share with us, and then we can stay on the call for those who have additional questions and try and answer as many as we can, and if not, then address those and follow up email or through the IGHS website. So moving on with Joe Novotny, thanks very much for taking your time. Joe is the inaugural director of an important entity that we all should be familiar with, and that's the International Research Support Operations Office. The goal of this office, which was recently launched, is to provide effective and efficient operational support and expert advice to faculty and leaders on campus who are engaged with international research. Joe has extensive global health experience, was the global malaria advisor for the Clinton Health Access Initiative, as well as a variety of other global health leadership roles that Joe has taken. We're very lucky to have him at UCSF, and thanks, Joe, for taking the time on this call. Appreciate it.
Yeah, thanks, Mike. I want to make sure we have enough time for Winona as well. Just to say that, I think when we developed this office, we knew that communication would be an issue that we wanted to work on. And I think the COVID-19 pandemic has brought up that weakness very clearly. We have not established a communication network campus-wide for international researchers, so we are definitely relying on IGHS and the International Faculty Affiliate Program for communicating with people. But I would say, if you know people who aren't involved in that but are involved in international research, please share resources widely, making sure they get those. And as Jaime said, we'll continue to work together and collaborate to bring resources together so we can all benefit. I definitely want to thank Bixby, Bases, and GSI, who kind of got the ball rolling on making sure that we had guidance for international researchers. Yesterday, an initial draft was sent out by Jaime for guidance for international researchers that is based on resources that have been developed in the Office of Research, but also things that are more specific to the international community, especially around travel, and I'll talk about that in a second. But you can find a link to that if you don't have that email on the right-hand bar of the IGHS website to that document, and we'll update it as new information comes in. So jumping into what is in that document and what's important to talk about today, just to note that the U.S. State Department has announced a level 4 global travel advisory yesterday afternoon. Its notice is for all U.S. citizens to avoid international travel, and for U.S. citizens currently abroad should arrange for immediate return to the United States. If they can't or do not want to, they should be prepared to remain abroad for an indefinite period. I think UCSF leadership is considering what are the implications of this travel advisory in terms of staff that remain abroad, whether they should come back or whether they should be encouraged to come back. Our advice currently is at least to make sure that the people abroad and their supervisors are in contact in terms of repatriation to the US, if that's an option. One thing UCSF does not control is whether political borders are closed or whether flight routes are canceled. So there might be a small window to make that decision, and we should take it seriously at this point in time. The other thing people were asking for UCSF advice regarding their research projects. I can only say that beyond the advice that we can offer from the Office of Research, we're governed by the host country laws and parameters set by our local collaborating partners. So even if we think something is essential or we want to continue with the research activity, we do have to follow the laws of our local country, and we have to listen to our local collaborating partners. So we can provide some pathway forward, but I think it's important that researchers continue to have an ongoing conversation with their local counterparts about the situation on the ground and the rules that are being enforced there. And as we all know, the situation is evolving, but there is now a specific site for research guidance on UCSF's COVID-19 website. And part of this advice is about determining what activities are essential. I know we have a lot of people working with HIV patients who need to maintain their care, TB patients who would probably have complications with so I think it's up to the principal investigator to decide what is essential. But again, we're adding another piece to this that we don't have on the campus, which is our local counterparts. So we have to make sure that we're talking with them in terms of determining what's essential for our study participants. And there is a guide on that for campus decision making, but it can be also applied to international as well. So please use that, and that's available again on the website. You could also consider conducting work remotely, and that does not require pre-approval. So I know the connections and networks abroad are probably limited, but if there is an opportunity to do some work remote, it can be considered. And this is my last slide, and I know in terms of helping our local partners prepare for the COVID-19 epidemic, and different countries are at different places and have different strength of surveillance systems, so it's hard to say. But UCSF has developed a guide for screenings of research participants regarding COVID-19. So if essential activities are going to be maintained, this can be adapted to the local context to be provided to our local partners for institution there. And there are also additional resources developed by UCSF Health for managing COVID-19 clinical issues among healthcare staff that I think, again, can be adapted and shared with our local partners if it helps them better manage the epidemic. With only 7 minutes left, I want to hand over to Winona, and then I think we could take questions with whatever time we have remaining.
Sounds good. Thanks very much, Joe. Appreciate the updates. Without delay, Winona Ward, Ms. Ward, thanks for joining. Ms. Ward is the Assistant Vice Chancellor of Research and Interim Director of the Office of Clinical Trials Activation. She oversees UCSF-sponsored research, which includes research management services, government and business contracts, industry contracts, division, and subawards. She's also responsible for the Office of Clinical Trial Activation, including calendar build, coverage analysis, and budgeting for clinical trials, as well as the UCSF Clinical Trial Management System, Encore. Thanks very much for taking the time.
Thanks, Michael. I do not have slides, but I am sharing a link to the Office of Sponsored Research website in the chat. Well, what we're focusing on in OSR is right now gathering information regarding the impact of research funding. I will just say quickly that the federal government recognizes that there will be delays in research progress. There will be unanticipated costs. There will be researchers who cannot meet deadlines, including financial reporting, RPPRs, and the like. So, you know, the most important thing from the feds, the NIH, CDC, et cetera, is the safety and welfare of human subject participants and researchers. And so they have issued guidance regarding flexibilities. We are marking that guidance. It changes, and we get more in daily. So just know that via that website, which I've just sent in the chat, OSR is working to synthesize that information, make sure that we have the most up-to-date information, as well as provide information to PIs as it becomes available. Any flexibilities from the federal government for grants, contracts, cooperative agreements do flow down to our subrecipient entities automatically. There does not need to be any modification or any authorization from UCSF in order for our subrecipient, sub-collaborators to understand that flexibilities and additional costs related to COVID-19 do apply to our subrecipient collaborating institutions. There are also some funding opportunities related to COVID-19, which we have posted on our website, and we have also distributed that widely across UCSF. The office-sponsored research is 100% operational, and we are remote. We are still able to submit proposals and to prioritize all COVID-19 research. There will be availability for administrative supplements, emergency supplements. Those announcements are already up by way of the NIH, and we're ready to help in getting those prepared and submitted for the campus. I'll stop there so that we can have time for questions.
Great. Thanks very much, Winona. Just as a quick note, we're not going to have time to get through all the questions, but Colin will help us get through some of those. We will be trying to make sure that the IGHS COVID page does have links out to relevant information resources that do address some of these questions, most of which will be, or many of which at least will be the UCSF Chancellor's COVID page. Colin, I'll hand it over to you.
Questions on the group chat, and in just the interest of time, the one that came up quite a bit was really around what UCSF and what IGHS and our teams are doing to help our partners in low-income countries. That is, I think, very consistent with what Sri's presentation and conversation was about, and I think we have to take that very seriously. At the same time, as an organization that's locked down, that can't travel there, that is facing our own challenges, we have to be very thoughtful about the types of support we provide so that we don't overpromise or deliver things that aren't going to be maximally useful to our partners. There are things we probably can do, though. And so what I'd like to do is propose we get a group of people who are interested in participating in that activity, thinking about how we can help our partners together to really identify a handful of key international partners, to talk with them, to understand where they are in the course of this epidemic, what their needs are, and see if there are very discrete and focused ways that we can provide either the right expertise, the right lessons from our experience, or other things to help them. And so if people are interested in playing a role in that, and I see there were a number of names in the chat about people who are particularly interested, please send me an email separately, and I'll follow up and we'll see if we can put a group together to try to make that happen. We have to avoid, I think, the issue of trying to do more than we can realistically deliver from here under the circumstances we're in. There may be ways to do that more effectively than others. In other questions, there are a few questions about upcoming events, HIV and the AIDS 2020 conference. Apparently that will be announced. And a decision on that will be forthcoming. And then there were a couple of other policy questions. Winona, anything on staff redeployment? Could you say a few more words about that if you're still on, based on what funders are allowing and not allowing?
Can you clarify, Colin? What
Yeah, so people whose salaries are covered on either NIH or CDC grants, being rediverted to local response.
I can't speak to whether or not the rediverted costs are going to be allowable, but I can say that the NIH has said that any institutional policy regarding charging of salaries for all staff during this period, this ramp down period, will be allowable on NIH grants. And so we're working to determine what that means and how costs can continue with stop work is what we're focusing on now. Redeployment to other efforts, meaning taking them off of the grants and diverting them to healthcare, for example, is a separate matter, which we certainly are looking at as well.
Okay. So
This is George. We've we had a long conversations with CDC over the last couple of days, and it's going to be allowable, but they want the program officers sign off on it. And there's some monetary limits about how much you can divert. This is actually for PEPFAR, but the rest of the agency has allowed it as well. But you just have to talk to the project officer.
Great, thanks, George. And then the other, there were a number of other questions that were much more about UCSF testing protocols, testing staff, and the like. This forum's not, I think, the right forum to answer that. Mike Lipnick, do you have any guidance on where we might find the best answers on that for folks, or what other town halls or the like people should participate in to get clarity on those issues?
Yeah, so there are a number that are ongoing. So, I mean, for all clinical questions, occupational health, despite the long waits, is going to be the resource that we are pointing everybody to. There is information on the UCSF Chancellor's COVID website, and we can try and on our IGHS COVID site make sure that we have relevant links and resources to point in that direction. The UCSF Medicine Grand Rounds, which is going to be recurring weekly on COVID, is also a great place to get information. It includes some of our critical care faculty, medicine, multiple disciplines joining in there. So another good site. And we're coming up on, we're at 9:01. So just to be respectful to everyone's time, I think we'll probably go ahead and wrap up there. Apologies for not getting to everybody's questions, but again, we will send out follow-up email. Please be in touch with Colin if you're interested in partnering up to address some of the issues that were raised today. Again, plug for Thursday Grand Rounds next week with George. Thanks everybody for taking your time. You know, there's a lot to cover, and we hope that by having some continued dialogue, we can start chipping away at some of these issues. And we'll be in touch soon about potentially another meeting in the coming week or so. Thanks very much for taking the time, everyone. Colin, George, Joe, Winona, Shri, thank you again.
Great.
Thank you.
We'll post figure out a way to get an audio copy of this on the website as well, or links somehow in Box, so people who couldn't join today, if any of your colleagues are interested, you can point them to that. Thank you. Have a great day.
Thank you.